Go ahead and get started. So good afternoon, everyone, and welcome to our breakout session titled The Economics of Cancer Care. I am so pleased to introduce our speaker today, Robin Yabroff, who's an epidemiologist and senior scientific director at the American Cancer Society. And there she leads a team of 6 scientists and conducts research on financial hardship and the economic burden of cancer care. So I'll be moderating this session today, so I encourage you to comment and ask questions using the chat box, and we'll also set aside some time at the end for questions and answers. But as Robin's going through her presentation, feel free to make comments and we'll get to them as best we can. So Robin, take it away.
Thanks so much, Lindsay. I am going to share my screen. So I want to start by saying how pleased I am to have the opportunity today to talk about economic burden in cancer survivors in the United States. It's a really important and increasingly discussed topic in many circles. So I want to start by providing a little bit of background about cancer survivorship in the United States. I think most of this will be familiar to many of you, but it's important when we start thinking about economic burden. So currently there are about 17 million cancer survivors, and for most cancers, incidence increases with age, and the prevalence of survivorship is highest in the elderly population. There are a couple recent trends that affect cancer survivorship. One is that incidence rates are mostly declining, and survival following diagnosis is mostly improving. But because we have this aging and growing population in the United States, we expect to have about 20 million cancer survivors by 2026. And so that's increasing, and it's going to continue increasing in the future based on the age of the US population. A couple other key features about cancer survivorship and how it affects cancer survivors in the US. As many of you know, cancer survivors can experience lasting effects of both disease and its treatment. And importantly, when compared to individuals without a cancer history, cancer survivors have greater risk for new cancers and other chronic conditions, greater healthcare spending, including out-of-pocket spending many years after completion of treatment, and also limitations in the amount or kind of work. And this is especially important because limitations in the amount of work or the kind of work can affect income, and it can also affect access to employer-sponsored health insurance coverage. And I'm going to talk a little bit about that in a minute. Additionally, research is increasingly showing that cancer survivors have increased risk of bankruptcy compared to similar individuals without a cancer history. So now I'm going to share some quotes from a study we did a couple years ago, actually in 2012, where we asked patients to talk about their experiences with financial hardship in their own words. And so this first quote I will read to you says that I'm still paying for debt accrued for my co-payments or hospital bills and credit card debt that was accrued during time out of work. Another cancer survivor said that they had to let their home go back to the bank after 20 years of home ownership. They had to file for bankruptcy. Another cancer survivor describes paying most of her costs out of pocket and saying that her savings were wiped out and that it's a considerable stress. And then finally, a cancer survivor describes how having cancer affects employment, that they stayed with a company that provides excellent health benefits rather than seeking a higher paying job where benefits may not be as good. So as I mentioned, that study was conducted in 2012, and since that time, there have been a number of trends that affect financial hardship. One is increasing treatment cost. Another is increasing treatment intensity. So more cancer patients are receiving treatment. They're receiving more intense treatment and for longer periods of time. Importantly, there's a lot of trends related to health insurance coverage. The first one listed here is high deductible health insurance plans. The prevalence has grown from less than 10% prior to 2010 to now more than 40% of individuals with employer-sponsored health plans have high deductible health insurance plans. That means that the insurance doesn't actually begin until after a deductible is met. There's also been a lot of changes in patient cost sharing, and I have in parens among the insured with higher co-payments and also co-insurance. And the co-insurance is especially relevant because it's a percentage of the list price of treatment. And so as treatment costs increase, co-insurance and patient out-of-pocket increases as well. Also, despite historic gains in health insurance coverage following the Affordable Care Act, we are now experiencing upticks in uninsured and underinsured. So those are people who have health insurance coverage, but it may not be as comprehensive. And then finally, something really important to mention, especially now, is the effects of COVID-19. With widespread unemployment and potential loss of employer-sponsored health insurance coverage, this is amplifying all the other factors related to financial hardship. And in this next slide, I want to share some recent trends with the monthly and median costs of cancer drugs at the time of FDA approval. So just to highlight the fact that in the 60s, the monthly cost of a new cancer drug at approval was less than $50 a month. And as we move through the 2000s and up through 2016, we see that increasingly, and you can see with my pointer, some of the new drugs are $50,000, $60,000, $70,000 a month, and they have continued increasing. And to the extent that those drugs are oral drugs, patients frequently pay a co-insurance rate of 30%. So, for example, if a drug had a monthly cost of $100,000, that patient might experience a co-insurance rate of $30,000 a month out of pocket. So another way of looking at similar information, I'm showing you now median monthly price of new cancer drugs, which is similar to what I showed you a minute ago, and then also median monthly household income, which has changed very little over time. So what you see, and this is only through 2014, but you see this increasing difference between household income and the price of cancer drugs. Now, importantly, the patients experience out-of-pocket spending for more than just cancer drugs. Scans, other types of treatment, supportive agents, hospitalizations, all of those factor into what patients pay out of cost. But the increase in the price of cancer drugs is something that seems to be driving a lot of the high out-of-pocket costs. And colleagues in Washington State recently conducted a study where they compared cancer survivors and those without a cancer history and looked at the risk of bankruptcy and the effects of mortality. And they found that among cancer survivors, declaring bankruptcy was associated with an increased risk of mortality. And these are an adjusted analysis, so which means that they're comparing similar individuals with and without bankruptcy. And they controlled for things like cancer stage, diagnosis, and type of cancer. And findings were very robust in sensitivity analysis. So this is a really striking and troubling finding, but the exact mechanism for how filing for bankruptcy might affect increased risk of death is unclear. Many have hypothesized that it might be due to lower quality of life or overall well-being, that those with financial hardship may be making trade-offs in terms of housing and food as a result of high medical out-of-pocket expenses, that increased stress that I mentioned earlier that some cancer survivors experience, and then also importantly, decreased treatment adherence or access to care. So there may be decisions made to not receive cancer treatment because of expected out-of-pocket costs. So consistent with those three mechanisms is this medical financial hardship framework that I'd like to share. And I'm going to use this framework to talk about some of our other research. So there are 3 components in this framework: material conditions, psychological response, and coping behaviors. Material conditions are things like high out-of-pocket expenses, trouble paying medical bills. Psychological response being that stress and distress related to high out-of-pocket expenses. And then coping behaviors are the things that patients do because of challenges with finances. And so that would be the delaying or foregoing care because of cost. And in this next slide, I'm sharing data from a nationally representative survey of financial hardship in adult cancer survivors. And here we report that about 7% reported having to borrow money or going into debt. 12% reported being unable to cover the share of the cost of medical care. And when I look at
Oh, Robin, are you back?
yes, I think we lost our connection.
Okay, sorry. I didn't know if it was me or you. I'm so sorry about that. Oh, the joys of a virtual conference.
It's fine. So it looked to me like I started to have, I'm going to share my screen again.
Okay.
And it looked like I started to have.
I think it was one more back, or maybe one more.
Hold on, let me do it. Yeah, there we go. I think I was sharing here, and then that's about where I lost.
Yep, that's where I lost you. So we'll continue here. Great. Thank you.
Okay. The main thing I wanted to point out in this slide is we did stratify our analyses by age group to reflect differences in employment and also age eligibility for Medicare coverage between those 18 to 64 and those 65 and over. The main difference I want to point out in this slide is that it's nearly double in that younger group, age 18 to 64 versus those 65 and older. So nearly 30% report any material hardship in the younger group compared to 14% in the older group. 32% report any psychological hardship in the younger group compared to 15% in the older group. And I think this is really striking, especially because those who are 65 and older are more likely to have comorbid conditions than that younger group. So really striking and a large burden on the working age population. This next slide shows prevalence of material financial hardship by age and type of health insurance coverage. The first thing I want to point out is the differences again by age group. So you see higher prevalence of financial hardship among those 18 to 64 versus those 65 and over. But we also see differences by type of health insurance coverage, with the highest prevalence of material financial hardship in those with public or who are uninsured compared to those with private health insurance coverage. But importantly, even those with private health insurance coverage, 25% report problems paying medical bills or having high out-of-pocket costs. Similar findings when we look at psychological hardship, that is the stress and distress related to high out-of-pocket expenses and financial challenges. Similar, same differences by age group. And in this next slide, I'm showing you data only for those age 18 to 64. And this is, we're looking at behavioral financial hardship. And so these are changes that people make in response to having high out-of-pocket costs or having financial challenges. Here I'm showing you green are previously diagnosed cancer survivors, red more recently diagnosed within the past 2 years, and then this blue color is those without a cancer history. So here we see that cancer survivors are more likely to report delaying filling a prescription, taking less medication, or skipping medication doses because of costs than those without a cancer history. And importantly, these findings that I'm sharing with you are fully adjusted for the effects of age, race, ethnicity, sex, educational attainment, comorbidity, health insurance coverage, and geographic region. So we really do see that cancer survivors are more likely to report financial hardship than those without a cancer history. And so as we've been conducting this research, one of our big questions is what is the size of the overlap of these different components of financial hardship? So is it that we're really measuring one basic domain, or are these potentially, it's a greater intensity for those who experience all three domains compared to those who experience one only? And so in this next slide, I'm sharing national data focused again on the cancer survivors age 18 to 64 by educational attainment. And the colors represent the intensity of financial hardship. So red represents multiple domains, green is one domain only, and this clear color is no hardship at all. And you can see a very clear pattern with those with less education having much greater financial hardship and greater intensity. And this is even greater, the disparities by health insurance coverage are even greater. So here what I'm showing is that among those without any health insurance, 87% report having at least one domain of medical financial hardship. And even though this is less than those with private health insurance coverage, still important to note that more than 65% report at least one domain of financial hardship. So far I've shared with you that younger age, lower socioeconomic status, and being uninsured is associated with financial hardship. Other research has shown that being unemployed, minority, race, or ethnicity, and living in a rural area are also associated with financial hardship. And so in summary, I've described some different aspects of medical financial hardship: material, psychological, and behavioral. I've also shown that financial hardship is relatively common, even many years following a cancer diagnosis and treatment. And this consistent evidence about patient factors that are associated with hardship, lower socioeconomic status, minority, race, ethnicity, being uninsured, younger age group, all of those things are also associated with many other disparities in cancer outcomes. And so really there's a concern for widening disparities for cancer survivors based on medical financial hardship. And so there are, of course, as a researcher, I have to say, there are some research gaps. And, we really don't know a lot about the trajectory of financial hardship. Like when does it peak? We do know that it's cumulative, but we don't know when it's at its highest following a cancer diagnosis. Very little information about health outcomes. There probably will be variation by cancer type, treatment type, or duration of treatment, but we have very little information about that. Caregiver burden is a really important issue, but we have very little information to date. There's also little research about provider, community, state, and federal policy factors that are associated with hardship. and very little intervention research to date that might address hardship and economic burden. And so in this next slide, I'm showing you a framework for thinking about research gaps in financial hardship and also where there might be modifiable levers for intervening to improve outcomes. Most of what I've shared with you are factors at the patient and family level, but other factors at the provider, healthcare provider, team, organization, practice setting, community environment resources, and state and health policy environment may also play a role in hardship and may also be intervention levers. And then importantly, I've added the employer level because employers make decisions about whether or not to offer health insurance coverage to their employees and what type of coverage to offer. They also make decisions about whether or not to offer paid sick leave, for example, that can make it easier for patients to complete their treatment. And so as we're thinking about potentially modifiable factors at multiple levels, there are factors at the patient and family level. Much research is focused on financial navigation, but we don't really know what the critical components of financial navigation are and what the role of health insurance coverage type might be. At the provider and team level, who is the best member of the team to discuss financial hardship? And should it be only one member of the provider team? At the employer level, thinking about what the business case is for offering health insurance and retirement benefits, paid sick leave, or workplace accommodations to ensure that patients receiving treatment can continue to maintain their jobs and also their employer-sponsored health insurance. And then at the practice health system, can documenting and addressing financial hardship play a role in quality improvement? And then finally, at the policy level, can health insurance coverage and benefit design be structured to minimize economic burden for patients? And then importantly, how has the Affordable Care Act affected economic burden and hardship? And I'm going to spend a little bit more time talking about the policy level. I'm going to talk a little bit about the Affordable Care Act, and some of the key components are the development of the health insurance marketplace, elimination of exclusions for pre-existing conditions, annual and lifetime caps, and co-payments for some preventive services, including cancer screening. There's the dependent coverage expansion, which allowed young adults to remain on their parents' private health insurance coverage through age 26, and then closing of the Part D donut hole. The component of the ACA I'm going to spend the most time on is related to Medicaid expansion, and I'm going to share some interesting findings from some of our research. And following Medicaid expansion, many reported a decrease in the percentage of individuals without health insurance coverage in Medicaid expansion states. And many of you know that the Supreme Court ruling allowed states to choose whether to expand Medicaid eligibility coverage. And so what that did is it created a natural experiment, which allowed us to compare the effects of Medicaid expansion in those states that chose to expand to those that did not. And so I'm going to share some of that research now. So this study is of newly diagnosed cancer patients starting in 2011 through 2014, and it's by quarter. And we are comparing Medicaid expansion states on the left side to Medicaid non-expansion states. And this is also stratified by income level. And the important color to focus on is this blue, which represents low income in expansion and non-expansion states. So what you see is starting in the first quarters of 2014, newly diagnosed cancer patients that were low income were much more likely to report that they had health insurance coverage. So the percentage uninsured went down in Medicaid expansion states, but not in non-expansion states. Importantly, when we look at low income patients in expansion states, and we look at the percentage uninsured, it becomes equivalent to high income patients in non-expansion states. So really we're starting to see the effects of Medicaid expansion closing gaps in insurance coverage. In another study, we looked at variation by state in percentage uninsured newly diagnosed cancer patients. And here I'm showing you Medicaid expansion status as of January 2014. And then I'm going to look at some comparisons of neighboring states where one expanded and the other did not. So here you see in Tennessee, which did not expand, the percent uninsured remained high, whereas in Kentucky, which did expand Medicaid eligibility, the percentage uninsured declined. Similar with Mississippi versus Arkansas, which expanded, Colorado, which expanded compared to Utah, which did not, Oregon, which expanded compared to Idaho, which did not. So in all of these state-by-state comparisons, you see reductions in the percentage of newly diagnosed cancer patients without health insurance coverage. In this next slide, we took the same information from that study and combined across all states and looked at percent uninsured by poverty. So this purple line here represents a higher level of poverty. 20% of the population live in poverty. And here you see this reduction in disparities in insurance among newly diagnosed cancer patients in expansion states, but not in non-expansion states. One other thing I'd like to point out is that the percentage of low income who were uninsured prior to expansion was higher before the ACA. And so we are seeing broadening differences between those living in poverty in expansion states compared to non-expansion states. This next slide shows similar information, but by race ethnicity. Here we also see, in 2014, we see narrowing of disparities in expansion states, but not so much in non-expansion states. This next slide is from a study where we looked at cancer survivors from all 50 states, and they are stratified by income level. Again, expansion on the left, non-expansion on the right. Income, the low income, middle income, and high income. And here you can see that starting in 2014, the percentage of cancer survivors reporting being uninsured declined dramatically, and disparities by income diminished by 2017 in expansion states, but not in expansion states, non-expansion states. And in fact, you start to see an uptick in the low income population in non-expansion states. This next slide shows similar information, but this is instead reporting the percentage of cancer survivors who say they did not receive care because of cost in the past 12 months. Similarly, disparities by income level, diminishing in expansion states, but actually starting to increase a bit in non-expansion states. So now I want to talk a little bit about where we are as of August 2019 in terms of expansion. There were still 14 states that did not expand Medicaid. I want to focus your attention to the southeast portion of the US that I'm drawing a circle around with my mouse, and also share with you some information about health insurance coverage of the non-elderly up to age 64 who are actually below 100% of the federal poverty line. And so for an individual, the federal poverty line is about $1,000 a month or $12,000 a year. So again, focusing on the southeastern part of the United States, you can see that between 22% and 31% of those living below 100% of the poverty line were uninsured. Many of these non-expansion states, compared to other states where a much smaller portion of the population that are poor were uninsured. So in this next slide, I'm showing you geographic disparities in cancer mortality, and this is among males, and this is in the years 2002 to 2011. Again, I want to focus on the southeastern part of the United States, many of those expansion states, which have cancer mortality rates, the highest cancer mortality rates, which is in red, compared to the lowest cancer mortality rates in blue. again, highest cancer mortality rates in many of these states that chose not to expand Medicaid for their eligible population. Based on all of the data I've shown you so far about the effects of how health insurance coverage has reduced disparities, and that these data are prior to the Affordable Care Act, one of the big concerns we have going forward is that the disparities that existed before the ACA are only going to widen in the future. So as I wrap up, I want to talk a little bit about health insurance coverage and medical financial hardship and potential breakdowns across the cancer control continuum. And this is a continuum we frequently think about in terms of where to intervene to improve cancer outcomes. So risk assessment, screening and detection, diagnosis, treatment, survivorship, and end-of-life care. And those without health insurance coverage who can't afford to seek health care may not get risk assessment or behavioral counseling and smoking cessation, for example. They may not receive screening or symptom evaluation should they develop symptoms of cancer. If they are able to receive screening and have an abnormal finding, they may not follow up those abnormal findings and then may not get a timely diagnosis. Those without health insurance coverage or who have medical financial hardship are more likely to underuse effective treatment. And they're also more likely to not have early palliative care included as part of that treatment. They may be less likely to receive coordinated survivorship care and also lack of coordinated palliative care at the end of life. So there are multiple places along the cancer control continuum where having health insurance coverage can make a huge difference in outcomes for cancer patients and survivors. So with that, I'd like to finish and I'm looking forward to your questions. Thanks for your attention and sorry about the loss of screen sharing.
Thank you so much, Robin. You always have like such great data and the graphs are really helpful to see how financial toxicity impacts cancer patients. I mean, most of the advocates know all too well, some personally, the impacts of financial toxicity of cancer care. And as we go into our Hill Week, this information is so useful for us to really understand like big picture, how the policies have helped improve or what policies need to be changed in order to alleviate some of this financial burden on patients. And so we had a couple comments from our audience and someone who said that they are a recipient of the ACA or a beneficiary of ACA Medicaid expansion, and that they've been diagnosed with breast cancer 3 different times and were different stages of insurance each time. So one was an underinsured, one was uninsured, and then one through the Medicaid expansion. And regardless, has still struggled. And what she is really talking about is that her income potential in her career was just totally thrown off by this diagnosis. So do you have data or can you shed a little bit of light on that, the income potential? I know you mentioned the changes in workforce and working to address what she's talking about.
And I think that's a wonderful question, and it really highlights an important issue for many cancer patients, survivors, but also for their caregivers. Because many caregivers accompany patients to treatment, and it may affect their employment as well. So there are some data showing that there are long-term effects on cancer survivors in terms of employment and in terms of, it's complicated because a lot of health insurance coverage for the population under 65 is employer-based. And so in many cases, it means that patients, cancer survivors and patients may stay in certain jobs because it has good benefits, even if they means turning down a position with greater potential or greater income if those benefits aren't nearly as good.
Right.
But it is a more complicated issue. And I will say that I am glad that the person with the comment was able to take advantage of Medicaid expansion in her state or his state. I apologize for the gender.
And I think too, something that I didn't know until working in this field, the big issue of being underinsured.
Mm-hmm.
And especially with this administration, we've done a lot of work on underinsurance and things like the short-term limited duration plans where, it could be really appealing for someone because of the low premiums or low out-of-pocket. But when it comes, eventually, we're all just one, step away from getting sick, and then they don't realize that their policy wouldn't cover anything that they might need.
Right. And many of those short-term limited duration plans don't cover things like prescription drugs or prenatal care. And importantly, they're not regulated in the same way as other Affordable Care Act compliant plans are. And so insurers can decline coverage based on a pre-existing condition. So for example, if someone has one of these short-term plans and they have a cancer diagnosis and then they want to renew that plan, they can be denied coverage because then it's considered a pre-existing condition.
Wow.
I know. I think it's really dangerous because many people assume that they're what we would consider to be health insurance coverage, and they're not.
Right. And I forget too, a lot of times, like we get on all of the terminology and vernacular that we use every day, and someone asks, what is Medicaid expansion and who decides this? She says she lives in Florida and wants to know the impact of non-expansion states.
Yeah. So that's a great question. So the states decided, so what happened as part of the ACA, the original intent was to provide incentives, federal incentives for states to expand eligibility up to 138% of the federal poverty line. And so that's a little bit above the federal poverty line. You may remember I mentioned that in 2017, it's about $1,000 a month. $12,000 a year is the federal poverty line. Many states chose not to expand eligibility, and in some states, eligibility is 17% of the federal poverty line. So 17% of about $12,000 a year is what you have to, that is how low income needs to be in order to qualify for Medicaid in those states. The Supreme Court ruling allowed states to make decisions about whether to expand or not. Unfortunately, health insurance coverage became highly politicized, and many states made the decision not to expand eligibility. I don't know what the threshold is for Florida off the top of my head.
But they did not expand, is that right?
They did not expand. But in many states that did not expand, so not only is the threshold low for a family, in many states that did not expand, individual adults without children are not eligible for Medicaid, no matter how poor they are. And so, back to some of those slides I was showing you about, the really striking pattern of Medicaid expansion and higher cancer mortality rates before the ACA. When we start comparing, my concern, my very strong concern, is that any disparities we've seen to date are going to be dwarfed by growing geographic disparities based on where people live, which is very unfortunate. And those, people without health insurance coverage are generally not eligible for many of the new, if they cannot afford to pay out of pocket for some of the much more expensive cancer treatments, we are going to, as a country, we are going to be increasingly rationing care based on the ability to pay.
Yeah. And I think too, something you kind of touched on, but and the COVID-19 situation just exacerbates that even more.
Yeah.
Um, and so I'm curious, so one of our Hill Day asks for this week is to expand paid leave to include cancer survivors who need extra time off work, because their oncologist is recommending that they stay home because they would be compromising their health by going back into the workforce. And so you talked about workplace accommodations, and one of our patient story that we use on the one pager was someone who was denied workplace accommodations, but just still has to go back to work. She said she feels like she's playing Russian roulette with her life, and it's just
Yes.
absolutely horrendous to think that that's where we are right now. So can you talk a little bit about the other impacts that COVID-19 is having on access to care right now, or that you might anticipate to see in the future?
Yeah, I mean, it's a really good point, and it's an area we're actively engaged in research, trying to understand, not only to understand how it's affecting cancer patients and survivors, but importantly, are there things that could be done to minimize that adverse effect? So, the most obvious effect of COVID is the widespread unemployment. And so I saw an estimate that I think it was through mid-May, as many as 90 million Americans were in a family that was affected by some form of unemployment due to COVID. And so this is, spouses, children, but that it is widespread effects. And for those who want to maintain their health insurance coverage through their employer, if they're newly unemployed, they can go through COBRA, which means they will pay their own portion of their health insurance coverage as well as the employer portion of the health insurance coverage. So it's more expensive than it would have been before. Some states are seeing a surge in Medicaid applications. Unfortunately, in those states that did not expand Medicaid eligibility, it may be much more difficult for the newly uninsured to gain Medicaid coverage. And some states are reopening their marketplace coverage, which allows individual purchase of health insurance. So those are the initial big picture things that we're seeing. And there have been a number of reports showing declines in cancer screening. A number of professional societies have made recommendations for which patients can safely delay treatment. I mean, one of the big concerns is that if cancer patients are immunocompromised because of their treatment, they may be at higher risk of a COVID infection. And so, that's exactly when having workplace accommodations may be the most important. But employers are not required to offer accommodations. And unfortunately, many of the employers that don't routinely offer paid sick leave to all their workers tend to be like food service. They tend to be industries that for lower income workers in the first place, who may not be able to afford to take time off from work, because if they don't have paid sick leave, they won't get paid if they don't work.
Right.
So, yeah, it's very unfortunate. And I will say that the COVID pandemic is really, really exposing a lot of the challenges we have with public health in this country.
Yeah. And you mentioned certain states deciding to do an open enrollment in one thing. And we're actually working with the American Cancer Society on this, but pushing Congress and this administration to do a nationwide open enrollment period because of the extreme loss of jobs and because of COVID-19. And someone also mentioned, how can patient advocates use our experience to make positive change. And that's what we're going to dig deep into tomorrow. So tomorrow is going to be, we're going to go over our legislative asks and talk about how you can connect with your members on these issues, especially. And so I just have another question, and it's about Medicare. And pretty big question, but you always have such great data. So here we go. So you mentioned earlier on in your slides that there's, this growing population of aging folks in the system. So how do you see Medicare changing to adapt to that? And how, especially, I guess, for cancer care? I mean, I know you're laughing, but it's such a good question. Tell us what will happen with Medicare.
Yeah, so thank you for that very simple question. Yeah, I mean, Medicare, I mean, as most people know, Medicare is fairly complicated. And so I think there's a lot of pieces that are important. So increasingly, Medicare beneficiaries are enrolled in managed care. So it's also called Medicare Advantage. And the financial implications for cancer patients and survivors are a little bit different if they are in the Medicare Advantage compared to the Medicare, what's called fee for service. And what that means, fee for service means is that providers are reimbursed based on every service that is provided for patients. Whereas Medicare Advantage tends to be more primary care and care coordination oriented. Okay, so that's some like basics on Medicare. For those who have Medicare fee for service, many also have private supplemental coverage from either their employers that's offered as part of retirement, or they may purchase private supplemental coverage separately. So I didn't share these data, but for those Medicare beneficiaries who do not have any additional supplemental coverage, they tend to have much higher financial hardship because they're paying a lot more out of pocket. What the supplemental coverage does is sort of wrap around and pick up some of the expenses that patients would be responsible for otherwise. So back to your earlier question of what does the aging population mean for the Medicare program? Is that?
Yes.
Yeah. It means that spending on cancer care is going to go up in the future. And it's going to go up quite a bit. So we actually published a study maybe last week or the week before. We looked only at the aging and growth of the US population and looked at current trends in cancer incidence and survival. And we found that about just between 2020 and 2030, we expect that Medicare spending will increase by more than 30%. I think it was like 34%. Wow. Just based on the aging and growing population.
And with what you mentioned about prescription drug prices, I'm sure that accounts for a lot of that.
Yeah. And I will also say that unfortunately the data were a little bit older. So my guess is that 34% is a vast underestimate. Mm-hmm. But it also means that, for example, Medicare Part B, as in boy, which covers infusion drugs, patients have a 20% coinsurance for any drugs they receive under Medicare Part B, as in boy. And so that as the drug increases, the out-of-pocket responsibility increases. For Medicare Part D, as in dog, that is oral prescription drugs. And cancer drugs are typically listed on the specialty drug tier. And a common coinsurance rate is about 30%. So back to that example of the $100,000 drug, the patient without any supplemental coverage will be responsible for $30,000. and out of pocket. So it, um, so it doesn't necessarily mean that the average patient out of pocket cost will be higher, but based on some of the other trends we discussed earlier, it is likely that they will be higher in the future.
Oh, yeah, that's incredible.
Yeah.
And your slides showed too, I think, how much of a financial burden the prescription drugs are on patients and how they're either not taking their prescriptions or, we hear from people all the time, they're cutting them in half. And
Yes.
obviously it's not surprising then that their health outcomes are worse and mortality rates are worse for those people. It's just devastating. I did want to touch on too. So you mentioned about the having conversations about financial toxicity and who might be the right person to do that. And one of our other Hill Day asks is yet again trying to push for cancer care planning, and especially right now when there's so many disruptions in care, that this is a time when cancer patients really need that that care planning piece. And part of that conversation, it's not just a hard document, it's also a conversation that we want patients to have with their providers. Do you have data on the effects of those conversations on financial toxicity? So patients who have providers who bring it up or talk about it, or institutions who have financial navigators, what the difference in their care outcomes is.
Okay, so that is a great question. Unfortunately, we don't have a lot of those research findings. There have been a couple studies showing that about 25% of cancer patients report that any physician ever, any physician at any time since their diagnosis ever talked to them about the costs of care. And there are a lot of reasons why it is complicated. If you don't know, for example, the type of health insurance coverage or the details of the health insurance coverage that an individual patient has, it can be complicated to know what that exact out-of-pocket expense might be expected to be. And many providers don't know the expense of what they're recommending will be for the patients. But I usually, even if it's not possible to know the exact out-of-pocket cost for a patient, I think it is really helpful to provide relative information about what the expected cost might be. And so I typically say, even if you don't know exactly, you might know whether the cost of treatment is going to be the cost of a fancy coffee, or a used car, or 4 years of tuition at a private college. And you probably do know which one of those three general categories the cost of care falls. So it is an area people are very actively engaged in research, but it's hard to know exactly what the effects of those conversations might be. I think it's a really important area for research going forward, especially because we are seeing more financial navigation. And many of those financial navigators are hired by hospitals who can help ensure that cancer patients have they can receive their care and they have fewer challenges with bills while they are receiving care at the hospital. But I don't know what happens to those patients after they complete care. And, a lot of the financial challenges with cancer are long lasting, and there's some suggestion that they can be cumulative.
Yeah, and somebody commented just earlier, I'm trying to find it, on that exact topic, just saying that it wasn't, they managed to pay for their care throughout, but it was like the long-term effects of like the follow-up care and the medications and the co-pays and so forth. And for a lot of patients, that's, for the rest of their lives. So Yeah, absolutely. And unfortunately, your comparison to the cost of care and a 4-year college isn't completely absurd. That's
No,
very real.
no. And the 4-year college tuition is not inexpensive either. I mean, it is,
Exactly.
yeah, it is. Yeah, yeah.
So thank you so much. And thank you all for your amazing questions. We had several comments of folks asking for the slides. And so I also just want to put a plug for on the website and your registration email. If you check that out, there are recordings of all sessions listed there. So this session will be posted later today. And Robin, if it's okay with you, I'd be happy to pass along slides.
Yes, absolutely. I think I sent a PDF of my slides earlier, and my email is really easy. It's my name, robin.yabroff@cancer.org. And I'm more than happy to answer any additional questions or maybe provide copies of the underlying research papers that the slides came from.
Wonderful. We appreciate that so much. And thank you so much for taking the time and really helping us set the stage for tomorrow and talking about some of the actions that we're going to take to address these issues that you talked about. So thank you so much for the work you do and for joining us today.
Oh, thank you so much. As I said earlier, I'm really pleased to have an opportunity to talk about this topic. I think it's really important for patients and their families. So
Absolutely.
thank you all and have a good day tomorrow.
Thanks. Thanks, Robin.
Bye-bye.